Yes, perfect. Thank you.
No problem. Yeah, it's still, this computer is very slow and everything's still loading, so I apologize. All right. So hopefully all this works. Basically the point for today is, I think the last time we focused mainly on left ventricular function. So today I wanted to switch gears a little bit and talk more about right ventricle size and function, and then also talk about lower extremity DVTs, because I think both of those go hand in hand and are probably underutilized or underassessed at the bedside, but something that can be done very quickly. So before I really get into the nitty gritty of the PowerPoint, I do want to get your guys' input. So I have my own QR code with a nice pre-test. So if you guys, it should take less than 5 minutes. But if you guys, I would really appreciate it if you guys could all just take a quick look at the pre-test and work through it really quickly. And really the pretest is just to assess, what your guys' thoughts are on with, right ventricle size and function, general comfortability with, DVT assessment, discovering DVTs, and just a quick, knowledge basis, just so that we can, see, if we end up finding the lecture that I'm going to be giving, helpful, hopefully, but we'll see. So if you guys can just give you guys maybe a couple minutes just to do it. So maybe, until like 1:13, 1:14, and then we'll get to the talk. Sorry, and I'm just waiting on a little bit longer. I know it's awkward, we're just all sitting here in silence, but I just want to really give you guys enough time to do the questions. I see there's been a fair amount of complete responses, so I appreciate it, but we can maybe increase the number slightly more. I'll try and hold the awkwardness on for a little bit longer. We'll do one more minute, one more minute. All right, and then just if there are any stragglers who logged in a little bit late, if you guys don't mind just trying to do this pre-test as early as possible, I'm going to leave this QR code up for about 10 more seconds. So if you guys want to quickly, if you haven't done the test yet, just either try and scan the QR code or use the link that's at the top of the screen to complete the pre-test. And then with that being said, we'll get to the talk. I appreciate everyone who's able to do it. I don't know what you guys' thoughts on the test was, if you guys felt good about it, if you weren't sure what the answers were for some of the questions, but hopefully by the end of the talk, you guys will feel much more confident. So basically what we're going to do is we're going to start by first evaluating the right ventricle. So how best do we evaluate this? So in general, it's best to estimate the RV size using a 4-chamber view. And so that's either with the subcostal or the apical 4-chamber view. And we say subcostal usually is better just because it tends to be the easier one to acquire. And it also provides us the best view of the right ventricular free wall. And that's the wall that comes up closest to the liver surface on the view of the subcostal. And we'll look at some examples. And this is important because if we're trying to see if there is some RV enlargement, if it's an acute or chronic picture, we may have to pay attention to the wall thickness, because the thicker the wall, the more likely the patient might have RV hypertrophy, and therefore it might be some type of chronic process going on. In terms of normal dimensions for the right ventricle, right? So we usually measure them in 2 separate areas of the right ventricle, and that's at the base or closest to the tricuspid valve. And generally the cutoff is between 4 to 4.1 centimeters or less. Anything bigger is enlarged. And then we also measure it in the sort of a mid-diameter view. And that is less, the number that they use in the literature is less than 35 millimeters. If you are only able to get a look at the RV during a parasternal view, you can look at the RV outflow tract diameter, and this is the long axis view, and that's usually going to only be 20 to 30 millimeters. RV normally, because the pressures are so low, should have very thin walls. So if you see a wall that's greater than 5 millimeters in thickness, that automatically denotes right ventricular hypertrophy. And it might make you thinking that there's a chronic process going on, like a pulmonary hypertension that's leading to the increased RV thickness. In terms of just generalized signs of RV dilation, so similar to like LV function, right? We sort of denote RV size just as basic, quick measurements. And so it's either normal, mildly enlarged, moderately enlarged, or severely enlarged. And really, the best, for us to say that the RV is normal, it should be less than 2/3 the size of the left ventricle. So it might be half the size, it might be even smaller than that, but it should be no more than 2/3 the size of the left ventricle. If, let's say, we're saying that the RV is mildly enlarged, and that means that it's somewhere in between it's closer to the size of the left ventricle, not necessarily bigger than the left ventricle, but certainly bigger than 2/3 the size. Once we say it's moderately large, then at that point, the right ventricle is sort of equal in size to the left ventricle. So it's hard to delineate which ventricle is larger than the other. And then of course, if it's severely enlarged, then the right ventricle is just greater than the left ventricle. And so why do we care about assessing RV size and function? So why, like, what might this be important for? And feel free to comment in the chat. And if you have any questions at any time, just let me know as well. Oops. Yep. So definitely, like, yeah, if we're thinking about PEs or heart strain, right? If we're trying to classify the severity of PE, right? So yeah, excellent. Oh, why does this keep doing this? Hold on, sorry. Yeah. Absolutely. So this is like, I would say one of the more common tables we use, especially in pulmonary and critical care. So, when we decide to activate PERT, right? So I feel like that PERT is sort of like this buzzword anytime a patient has a pulmonary embolism, right? And we're like, oh, we want to get PERT team involved. So what is PERT team, right? So PERT is the PE response team. And basically that's a group of individuals that includes pulmonary specialists, critical care specialists, cardiothoracic surgeons, cardiologists, interventional radiologists. And what we do is we all review images and lab work together to come up with the best treatment plan for a patient who does have a pulmonary embolism. And so we have to decide, when do we activate this team, because there's a lot of members involved. And so generally the way we decide who gets a PERT activation is if patients meet criteria, if the PE is at least intermediate high risk. And so what does that mean? We use this chart here to classify those patients. And so this is sort of taken from the European classifications for PEs, right? So basically, what we're most interested in is this group with the intermediate high risk PE, right? So in a low risk PE, the patient's hemodynamically stable. They may have a low PESI score. They're probably not going to have any signs of RV dysfunction on echo or CT, and they probably will have negative cardiac biomarkers. Once you get into the intermediate risk, you need to figure out, is it's intermediate low or intermediate high. And so the main way we delineate that is by using the cardiac biomarkers and the RV function on imaging. And really, it's important. The CT tends to overread. It's overly sensitive at reading RV enlargement. And a lot of times when we do the echo, the RV is actually normal. So it's important, if you can, to try and do at least a bedside echo to really better assess what's going on with that right ventricle, because unfortunately, the echo techs are not available 24 hours a day, right? So we have to try and see what we can do ourselves. And so that's important, because if we do see signs of RV dysfunction on echo, then that increases the risk of that PE, and it may make us decide on what we should be doing next with that patient. So that's the main reason why I think delineating RV size is important. Oops. Oh, sorry, I'm going too much. All right, so what is normal? So this is just highlighting your classic apical four-chamber view, right? And so this structure here is going to be the left ventricle. This is the left atrium. And then you have your right atrium here. And then you can't see it fully, but you have the right ventricle here. And under normal circumstances, for us to really quantify or estimate the RV size, you need to be able to see the lateral or free wall of the right ventricle. And this you sort of have to imagine based on where we see the right atrial wall is, but the right ventricle is probably, the wall is over here. And so if this is the wall here, then you kind of would compare, okay, is this 2/3 the size or less? Is this bigger? Is this the same size? And I would say that this is an example of a normal RV, where the right ventricle is likely 2/3 the size of the left ventricle. If we want to go to a different example, so this is a different view of a different patient. Now we're looking at a subcostal view, right? And so this is the liver up top, which is being used as an acoustic window. And the first structure when you are using the subcostal view that after the liver is going to be the right heart. So that's why the right ventricle comes up first or closest to the probe. And then below it is the left ventricle. And then you have your right atrium over here. And then your left ventricle is all the way in the bottom. And in this view, as opposed to the other view, you can really make out the free wall right here. And you can really estimate the size of the RV by comparing it to the left ventricle. So in this view, they're closer in size to one another. I think it's probably bigger than 2/3 the size, but still may not be the same size. So this would be an example of a patient who has mild RV enlargement. Does this make sense? And now we're going to get in progressively bigger examples, right? So in this view, again, what view is this, guys? Yeah. Just going to be your apical four-chamber view. And so what do you guys think here? So this is the right ventricle here. This is going to be your left ventricle. And then your left atrium here, and your right atrium is here. And so compared to the first two clips we see right now, you can really appreciate that the RV is really at least the same size of the left ventricle, if not a little bit bigger than that, right? And so the free wall is going to be all the way over here. And if you compare the width with each other, they're probably at least somewhat the same. If not, the RV might be slightly bigger even. And so this would be an example of someone who has moderate right ventricle enlargement. Is there any other abnormal things that you see with this view? Yes, excellent. You guys are really good. Yeah, I agree. I think the RA, the right atrium, is really enlarged. That's like kind of almost what stands out the most to me in this view is the right atrium, and it's almost impinging on the left atrium here in this view. All right, so then in this final example, what do you guys think? So this is kind of, it's supposed to be a subcostal view, right? Yeah, the right heart is basically all of the right structures are extremely enlarged here. This is technically a subcostal view. You can't really make out any part of the liver though. It's probably, but this is the right ventricle here. This is the left ventricle below it. You're not getting a great view of the left atrium, but you're seeing a very enlarged right atrium here. And one of the other interesting findings that you should try and point out is how the septum sort of goes inward into the left ventricle, right? So this is a sign actually even that there's RV pressure overload, that the pressures in the right ventricle might actually be greater than the left ventricle, pushing into the left ventricle. And so this is severe RV enlargement and also would be signs of RV dysfunction. So this would be very not great for the patient to have these types of findings here. So moving on to talking about RV dysfunction a little bit further. So there's a couple of signs that we look for at the bedside when we're trying to assess whether there's RV dysfunction. And really we don't, as opposed to LV function where we try and quantify it, is it mildly reduced, moderately reduced, severely reduced? We really just say RV function is normal or dysfunctional. So we really only use those two findings when doing bedside echo for right ventricle. And so some of the main findings that we look at or look for when we do our bedside echoes is the first sign is if there's any septal flattening. So this is most likely are best assessed in the parasternal short axis view, where you have your left ventricle in the center of your screen looking almost like a nice donut shape. And under normal circumstances, your right ventricle is sort of like a crescent shape in the top left corner. But if there's signs that there's RV pressure overload, instead of a nice crescent shape, the RV is going to be very big and it's going to be pushing into the left ventricle. So instead of seeing a nice O shape or donut shape of the left ventricle actually almost looks like it's a D, where the septum is turning inward. So you have sort of a D appearance instead. And I see there's one question. Yeah, when you're measuring LV size, are you including the free wall of the LV? Oh, yes, that's a good question. Yeah, so you should only be looking at the diameter of the cavity. So the free wall is not included when you're looking for LV or RV size. Yeah. But that being said, you do measure the wall thickness separately if you're worried about like hypertrophy, or even if you're worried about like a dilated cardiomyopathy where the wall might be thinner than you would expect. So those would be the only times where you would measure the wall thickness specifically. And then if we see the septal flattening on the parasternal short axis view, then you certainly want to get a 4-chamber view and trying to quantify whether the right ventricle is larger than the left ventricle. And then the more advanced signs, which we'll get into a little bit more detailed, is the McConnell sign and TAPSY, which is more of an advanced echo sign, but it's helpful for you guys to know about because you'll probably hear about it from time to time. So this example here is trying to highlight the McConnell sign. And so McConnell sign, basically what it is during, if you have RV dysfunction, you get decreased movement of the lateral free wall here. And so when you have decreased movement of the lateral or free wall of the right ventricle, the RV apex, or the area of the right ventricle that's closest to the LV apex, looks like it's moving more than normal or hyperkinetic. So, but it's actually not actually hyperkinetic, it's actually normal movement. It's just that it looks hyperkinetic because the rest of the right ventricle is not moving too well. And really what you're seeing with McConnell sign is that if you just have to imagine there's like a trampoline at the apex and there's someone jumping up and down on that trampoline, pushing in the RV apex in and out, in and out, in and out. And so this is actually a real echo of a patient who did have a PERT activation. And this was some of the views that were sent in our group chat. And you can really see that the RV apex is moving in like a trampoline. You can't really make out the free wall too well, but this would be a patient that does have McConnell sign. So it would be someone that we would be worried about, would have some type of RV dysfunction. And, keep in mind, we tend to associate McConnell sign with an acute PE presentation, but it can be seen in other things as well. So it doesn't have to be an acute or RV failure. It can be a patient with chronic RV failure. As long as there's preservation of movement with the apex, you'll still be able to have that positive finding. Any questions about McConnell sign? I do want to talk about TAPSE. So TAPSE, what it stands for, and it's long names, that's why we usually just go by TAPSE. It's tricuspid annular plane systolic excursion. And so basically what we're doing with this advanced echo modality is we're trying to assess how well the area around the tricuspid valve is moving. And so in normal circumstances, there should be a decent amount of movement there. So if there's a reduction in movement, that might be another finding to suggest that the RV is not functioning well. And so how do we actually calculate TAPSE? So basically what we do is we have to identify the tricuspid valve, and we'll show you an example on the next slide, usually using the 4-chamber view. And then once you have a good view of the tricuspid valve, you want to use your M mode, right, in your motion mode, with the line that starts in the middle of your screen. You want to move that line over to the lateral aspect or edge of the tricuspid valve. And then you want to actually measure how that moves over time during systole and diastole. And so essentially you're measuring it from peak to valley. And a normal TAPSE should be 25 to 35 millimeters. Then there's sort of like an indeterminate zone of 18 to 24. But definitely if you're calculating TAPSE and you see that the lateral aspect of the tricuspid valve is moving less than 17 millimeters in a cardiac cycle, that denotes decreased movement or decreased function. And so this is what the TAPSE will look like. I have 2 examples here. The one on the right is probably you can see a little bit more clearly, but basically you have a view of the 4-chamber, right? And then where you have the left ventricle right here. Can everyone see my mouse, by the way? I feel like I'm pointing. Okay, good, just making sure. And then so you have your left ventricle right here, your left atrium, your right ventricle, right atrium here, and then your right ventricle. And so once you have a good view of the tricuspid valve, you put your M mode on, and you want to put the line overlying the lateral aspect of the tricuspid valve or tricuspid annulus. So that would be like right over, there's like a little prominence on the wall, like a little thickening that you'll notice when you do these views. And so that's exactly the point where you want to put the M mode. And then really this black is all the RV cavity. So that's how you can tell that this is the border of the tricuspid annulus moving over the cardiac cycle. And really what you want to do is you want to measure the height. So this is the valley and this is the peak, and the height, the machine is actually pretty sophisticated. It'll calculate it for you. So the height here is 21 millimeters. So this would be sort of someone with that indeterminate range. Again, normal is greater than 25 millimeters. And then this is another example where we have another view where you have your left ventricle here, left atrium, and then you have your right atrium and right ventricle, and then you have your M mode right over the lateral aspect of the tricuspid valve, close to the free wall. And then you want to look at this prominence that separates the right atrium and right ventricle, and you want to really measure the movement of this over time. And so this is the bright white spot moving over time. And really what you can even appreciate as opposed to the first view, that this one, it's not that pronounced. And when you measure the height, right, it's only 14.5 millimeters. So that would be a patient that does have signs of RV dysfunction. So I would say this is a little bit more of an advanced echo. It's something helpful to know about, but I would just try and remember the cutoff. So if it's definitely 17 millimeters or less, that would be abnormal, and that would make you think of RV dysfunction. Questions about TAPSE? I mean, it's hard. These are just examples. Obviously, you'll have to practice at the bedside, whether you're in CCU or an ultrasound elective, wherever you may be. So now I think what we're gonna run through some examples where we look at the RV. So if you guys can just in the chat comment on what you guys think. You can tell me, what the view is, and then what you guys think of the RV size and function. So what view are we looking at here? Yeah, excellent. And then so we have the the left ventricle here. Okay, and then we have the left atrium here, right atrium here, and then the right ventricle here. And then if we're trying to, trying to see, yeah. So I would say, this one's kind of tricky, right? So because I will admit it's not the best view in terms of, trying to find the free wall of the right ventricle, but I would sort of have to imagine that it's here. And if we're imagining it's here, what do we think about the RV size? Yeah. So I think, I mean, a lot of times, I think this is the reality when we're doing bedside echoes, we're not gonna get ideal views. So we have to sort of make our best guess. And I would agree. I think in this view, it seems to be less than 2/3 the size. So I would probably say at least the size of the RV is normal. It would be very challenging for me to comment on RV function just looking at this, but something else to denote, right, is that the septum is not moving inward to the left ventricle inappropriately. So that so that's one tell that maybe the function might be normal. And then another tell, if you can't really fully see the free wall, is you want to pay attention to what structure is in the apex of the heart. So under normal circumstances, the left ventricle should be the only thing occupying the apex of the heart. So if you were to see the RV, even if it only looks like a little sliver, but if it goes all the way up and takes over the apex, like if part of here was the right ventricle, that would be automatically abnormal, and that would already denote that the RV was enlarged. So that's another tell if you can't get the best view. All right, so then for this example, we have another, it's 2 clips here, so you can take a look at both clips. So these are, these are real patients, real PERT activations. So, sometimes the views are not ideal, but, it helps us if we see practice with these views, and certainly when you get your amazing views when you're practicing, then you guys will be able to tell right away what's going on. So we can start. So both of these are, all right, I think I kind of agree, but so what are the views we're looking at here? So what's to the left of the screen? Yep, so this is going to be your parasternal lung. And then so this is your left ventricle right here. You have your septum, you have your aorta, left atrium, and then your right ventricle outflow tract right here. And so keep in mind, it's not always a great surrogate marker of the right ventricle in total, but certainly if it's enlarged, it definitely makes you worried that the rest of the right ventricle might be enlarged as well. And then this is basically where you rotate the probe 90 degrees. So instead of pointing towards the right shoulder, now we're pointing towards the left shoulder. And so now we're getting the parasternal short axis view. And so you have your left ventricle right here, and you have your right ventricle up here. And so it's difficult to see because there's some lung that's sliding in and over it. But if you pay attention here, the donut shape here, right, is almost the same size as the right ventricle here. So normally the right ventricle should look like a little crescent moon shape. So the fact that it's bigger than that would make me worried that there is some RV enlargement for sure. And then if we look at another view with this patient, what do you guys think? Excellent. You guys are yeah, you're doing well. All right, so I see. Yeah, so I would pay, like, you were trying to estimate the RV size by comparing it to the LV, right? Yeah, and I agree. I think they're pretty similar in size, definitely more than 2/3 the size. maybe equal in size, if not very slightly larger even. So I do think this is someone who has moderate RV enlargement. We're asking, why does the RA look hyperechoic? It's hard to say. I can't really say what this is right here, to be honest. I do think this looks a little abnormal. I think it's a little bit of an off-axis view. And the only reason why I would say that is you're actually getting the aortic valve and aortic outflow tract. So I wouldn't be too worried about something going on here, but definitely I would want to look at it in other views. But yeah, this looks a little strange, I would agree. And the one thing I do want to point out too is always trying to see when you do have this view if there could be mechanosine potentially. I think there's some movement of the free wall here, but I do think the apex is moving in a little better than the rest of the free wall. So this is some patient that I do think would have a mechanosine as well. You can see it bouncing inward a little bit. All right, and what do you think about it in this view? So we have again your parasternal long view, right, on the left. Like very enlarged RV outflow tract here. And you can, another tell is normally it should almost look like a little circle at top, but you see how the RV outflow tract like goes all the way towards the LV apex here. So that's very strange, unusual finding. And there's also probably some pressure overload because the LV cavity almost looks small and it almost looks hyperdynamic, right? And like it disappears with contraction. So this is a patient that I'm already kind of worried about. And then if I look on the parasternal short axis view, right, you see your left ventricle down here. Normally, again, right, should look like a nice donut shape. And you see how it kind of looks like a D that's been rotated about 45 degrees, right? So it's a D right here. So that's with anytime when the septal moves inappropriately in towards the left ventricle and the RV looks enlarged, that's a sign of definitely RV dysfunction. And I agree, the RV looks very enlarged here. It's much bigger than the left ventricle. Actually, let me go to the next one. So I don't want to run out of time here. Okay. So I will say, and this is a patient that we had recently on the ultrasound elective that we were just practicing with, and this is what we found. So what do you guys think? Yeah, so I mean, I do think, there is stuff floating around in here that looks concerning, but sometimes you get just other aspects of the wall that's moving inward. And so it's probably not a thrombus, but we'd have to see. If it were thrombus, usually would be very mobile and moving much more, whereas this comes in, I think, with the wall. But certainly, yeah, so this is your parasternal short axis here, or long axis, sorry. You have your left ventricle, aorta, left atrium, RVOT. And again, the RVOT extends all the way down here, which is a very abnormal finding. What else can we appreciate in this view? And is it a pleural or pericardial effusion? So I would say this patient, it's kind of a trick question. I think that this patient actually has both. So you always want to try and identify if you see black below the heart, you always want to know, okay, is this pleural or pericardial? So we use the descending aorta as a marker. And I think, you have to imagine it, but I think the descending aorta is down here. This is actually a coronary sinus, which you usually we can't actually see that well at the bedside, but you can see it in this lady here. And this rim of black right here, this would be the example of a small pericardial effusion. And then this black here would be pleural effusion. So she has both, I would say. And then what do we think of the parasternal short axis? Yep. So, I mean, the Rb is huge, right? I mean, it looks like it's almost double the size of the LV. But what's interesting here is that, as opposed to the last views we looked at, right, where we got the D sign, the structure of the LV is still very circular, right? And the squeeze of the left ventricle is pretty good. So to me, this would sort of signify that whatever's going on with the right ventricle is probably somewhat chronic, and that the other aspect of the heart has been able to compensate. So this patient actually does have very severe pulmonary hypertension. And actually, we can take a look at the apical 4. Whoops. So what do you guys think of the apical 4? Yeah. Both chambers are extremely large. There's almost looks like there's like 2 atria here. There's like a strand of stuff going into the right atrium, along the right atrium, but I think there's probably just some fibrous material within the right atrium. And then you have a very large right atrium, right? You have your right ventricle, and you're probably at the lateral aspect of the body. So the RV extends as long as the left ventricle and probably takes up a large part of the apex of the heart. And then I also want you to look at the tricuspid valve here. So what do you notice about the tricuspid valve? Yeah. Yeah, so you can see the it doesn't, the 2 leaflets don't connect and meet up, right? So the right heart is so enlarged that the tricuspid leaflets can't even fully close, right? So this patient, even without adding color, I can tell you right now, this patient has at least moderate to severe tricuspid regurg. And that's what she did. Actually, they said it was very severe tricuspid regurg, even on her formal echo. And then this is just highlighting the final view of her when we took a look at her IVC. I mean, it looks very, very dilated. I think when they actually formally measured it on echo, it was like 3.5 centimeters. And you can even see the hepatic vein is very dilated as well. So this is someone who has definitely chronic RV overload and is very overloaded. So this is someone you might want to try and diurese, and if they are hypotensive, to even diurese while on inotropes. All right. So that, we have about 10 minutes left. I just want to go over the bedside DVT study as well. Unless anyone has any other questions about the right heart.
I have a question.
Yep.
Just what we just saw, what you said, like if it's a donut sign, then that means it's more acute versus what the changes that we saw on the short axis here.
Yeah, and I think the donut sign really just means that the RV there's excessive pressure overload with the RV, and that there's going to be some type of RV dysfunction. So usually, I mean, if patients, I would say if it was an acute situation where that patient had that enlarged of an RV, you would expect some septal bowing. And so the fact that there wasn't septal bowing sort of signified to me that there was more of a chronic process going on. I didn't actually calculate the free wall, but if we were to try and calculate the free wall in another view, you could assess as well if there was hypertrophy, then that would be more indicative of a chronic picture. But yeah, so if you see a very enlarged RV and the LV is look like it's a nice circular shape, then there probably is been some chronic response or compensation for the finding.
Thank you.
Yeah, no problem. So for bedside DVTs, why do we do it, right? It allows for rapid assessment in patients that are too unstable or who can't go for more comprehensive tests, or if it's during a night, weekend, when formal testing is not available. The main considerations for doing them is if we're concerned for a DVT-PE, if the patient has undifferentiated shock, right? If they're hypoxic and we don't know why, if they have new RV dysfunction on bedside echo, and we want to see, could it be a DVT-PE that's playing a role. I will say POCUS DVT, it's designed to be quick. So it is limited to the common femoral branch points and the popliteal vein. So really, you go within a few centimeters of the groin, and then you jump down to the popliteal after that. And the reason for that is those are the branch points up in the femoral is the most likely area for clots to form, along with the branch points of the popliteal. And that being said, because we're missing the rest of the leg, we are missing about 10% of true DVT. So even if a bedside DVT study is negative, if you're concerned about a PE or a DVT, you should still get a formal DVT study, because the echo tech doing the DVT study will actually track the veins all the way down from the groin to the mid calf, which would be a little bit time consuming for us to do at the bedside. But keep in mind, we can get 90% of the DVTs by using just a quick few set of views. And anatomy is going to be important, right? So here's just a quick review of the anatomy for the bedside study. And so for our patients, right, we start with a common femoral artery, common femoral vein, and this is the right-sided anatomy. So if you remember, I think the mnemonic that I was taught was naval, right? So nerve, artery, vein, right, and lymph node. So the artery is going to be lateral to the vein, or more outward from the patient's. So on the right, the artery is going to be to the left of the screen, right? And so for you have your common femoral artery, common femoral vein, and the first thing that comes off is your greater saphenous vein, and that'll go medially up, and you'll see it usually at like 2 o'clock on the right, or 10 o'clock on the left. And so that'll be the first thing to come off. And anytime you see a branch point, that's a time where you want to compress to try and see if you see a DVT there. And then the next thing to branch off are the arteries branch into the superficial femoral artery and the deep femoral artery. And then a lot of times you'll see a vein called the lateral perforator going in between the two arteries. We used to call this like Mickey Mouse sign, because the arteries were like the ears, and then the common femoral vein was the face. I mean, it's kind of flipped, to the side, but you have to use your imagination for a lot of these things. And then the final thing to branch off would be the femoral vein. The deep femoral vein will branch off the femoral vein. So for your femoral views, you basically track down until you see these 4 vessels. And you really want to compress every centimeter or so, and every time you see a branch point. Once you reach this point where you see the 4 vessels, then you can jump down to the popliteal, and really the popliteal vein is going to be on top of the popliteal artery, and you just compress once, and then that's your quick DVT study. So in terms of proper technique, so positioning is going to be everything, right? So you want your patient to be completely supine, right? Otherwise, our patients a lot of times are fairly big, right? They might have their stomach overlying their groin and stuff. So you want them lying completely supine, so you can try and see the anatomy as best as possible. And the legs should almost be in like a frog-like position. So you want the knees to be slightly bent and your legs externally rotated. That'll provide the best access for getting the best views. And so you're going to be using your high frequency or vascular probe, and the marker should always be pointed to 9 o'clock. And so this will correlate in general to the right of the patient, and it will correlate to the left of your screen. And that's important, so that way by using this same technique, you'll be able to say which side, which should be the artery, which should be the vein. And so on the right, the artery is going to be to the left of the screen, which is the lateral aspect of the patient. And on the left leg, the artery will be to the right of the screen. So both will be lateral to the vein in relation to the patient. And so you want to assess at 3 groin sites and then 1 in the popliteal fossa. I trying to identify the inguinal ligament first. That's how you know you're at the common femoral artery and common femoral vein. And the inguinal ligament will just be sort of like a very bright hypercoic linear structure in the screen. Because a lot of times, sometimes if we start too low, we may miss all of the branch points. And you want to compress along the common femoral vein. So you want to keep that into the center of your screen and compress every centimeter. And really, you just need to have enough depth where the vessels of interest are in the direct center of the screen. So some patients, you might need to go 3-4 centimeters down. On really frail patients, you may only need to go a centimeter, even less deep. And you want to, the branching points are going to be the most common areas where clots form from the shear stress of the blood flow. So the greater saphenous vein will come off first, the common artery will bifurcate, and then the vein will bifurcate after that. And then when you're scanning the popliteal vein is very easily compressible under normal circumstances. So you really want to try and put as little pressure against the patient's skin as possible. Otherwise, you may miss the vein. So in terms of identifying a clot, right? So really there's three ways we can appreciate a clot. The most hopeful way that we can do it is by direct visualization. And in those instances, there are going to be hyperechoic objects seen within the vessel. You can kind of see here, right, and here. And this is a longitudinal view where you can see the clot all here. If you're not sure, but you see a lack of compressibility, so if you can't compress the vein, that means that there's a clot there, even if you don't see it. So that's going to be the most common finding you have. You may not always see the hyperechoic aspect of the clot, but if the vein does not compress, that means that there's a clot. If you're not sure, you can always add color, right? And so if you see partial obstruction or flow that's not throughout the entire vein, that might also mean that there's a clot. So some of the limitations of bedside studies, right? So smoke, sometimes you'll see, especially in patient with cardiogenic shock. So you'll see like almost like smokiness within the vein. That could either be that your gain is too much or the flow of blood is too little. So, but it doesn't necessarily mean that there's a clot. So you have to sort of look for other findings like lack of compressibility. Acute versus chronic thrombi. So acute thrombi classically are in the center of the vein, whereas chronic thrombi are going to be more adherent to the wall. But the chronic thrombi will tend to be a little bit more hyperechoic because as the body tries to dissolve it. And then some of the DVT mimickers, so we have two pictured on the left. A very common DVT mimic will be a lymph node where you'll see an area of darkness with a brighter spot in the middle. And the difference with this is that this will go in and out of view of your screen very quickly, whereas if it was a clot within a vein, the vein structure wouldn't disappear right away. And this here is highlighting a hematoma where you actually have an artery in the center and then some blood that formed outside the artery. I think this is from like an arterial stick gone bad or a femoral artery line gone bad, where you have a pseudoaneurysm almost forming. So, and then you could also sometimes, a lot of times, like a Baker cyst or something behind the popliteal can be tricked or making you think that there's a clot when there's not really there. So we're just going to go through a couple quick examples. So where is the clot here? So I'll say this is the artery here, and you can tell it's nice, small, circular, thick walled, right? And it's pulsatile. The veins here. And when we compress, you can see there's something hyperechoic and within the vein, and the vein does not compress all the way. So this would be a common femoral vein clot. And this is actually, yep, a right-sided femoral vein because the artery is to the left of the screen, which is the lateral aspect of the patient. Yep. So this is a right common femoral vein clot. Excellent. All right, what about here? So this here is the artery here, right? You can see it's pulsatile, it's thick walled, it's very round, right? And then this is the vein here. And, you know, there's partial compressibility, it doesn't compress all the way. And then when you really let go of the compression, you can really appreciate that there's something floating in the center of the vein. So this is a patient who has a left common femoral vein clot, right? Because the artery is to the right of the screen, which is the lateral side of the patient. And I think this is probably right where the arteries bifurcate. This, we're not seeing it clearly, but this might be the deep femoral artery that's coming partially into the view. All right, what about here? What do you guys think? So do we see a clot? So this was a DVT study that we had done recently during an ultrasound elective. And actually, so this is a trick question. There's no clot here. These are lymph nodes that are coming into view. And you see how they go in view and out of view really quickly. And, you know, they're a lot bigger than the vessel next to it. So these are just lymph nodes. So these are sometimes you can get tricked and think that you're seeing bright clots within irregularly shaped vein. But if you see this, always scan up and down, and then try and if it goes away right away, like these do, then these are just lymph nodes. All right, what about here? So just because we're running out of time. So these are left-sided clots again, right? So you have the left common femoral vein here, left common femoral artery, which is nice circular. And really when you're compressing, if you're compressing and the artery is compressing, then that's already harder than you need to do. Because what you don't want to do is you don't want to push so hard that you're like shove this clot upward. That might, cause a whole array of issues. So just compress enough where the vein should be compressed. So if the artery is compressed, like it gets here, maybe that's a little too hard. And this is maybe like right after or right before the greater saphenous. I'd have to imagine it. And then this is the arteries are bifurcating here already. You can kind of see the two arteries. So superficial and deep femoral artery. And then there's a small hyperechoic structure within the vein here. And these are just showing some clots again. This is actually at the level of the popliteal because the structures are more superficial. You can see a clot up here. And then this is another patient on the left. Actually, a lot of these are left. I don't know why, but so this is the left common femoral artery. This is the common femoral vein, and you can even see this bright white strand. It's going all the way up the greater saphenous and even into some branch of the greater saphenous. But there's a clot starting in the common femoral and then going all the way up into the greater saphenous and upward. So that would be a very large amount of clot burden. All right, I think that we're pretty much out of time. And any questions? You guys were excellent. I appreciate you guys for doing the pre-test. If you don't mind, please also do the post-test now. It'll probably be very fast, because now you're well equipped to answer all the questions. So if you can please, use the QR code here to do it again, and then. So the ultrasound dots, it'll be to 9 o'clock. So it'll be to the left. So if you're holding it, right, it'll be to your left, which will be to the patient's right if you're sitting in front of the patient. And that correlates with the left of the screen.
Dr. Rothman, do you guys have any other comments or questions? You can ask in the chat.